Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Hello, I'm here with Dr. Scott Nickerson, who is a colleague and a very personal friend of mine, and I think you'll enjoy this discussion. We're going to talk about nerve decompression for patients with diabetic peripheral neuropathy. Scott, thanks for taking the time to join us this afternoon. I know we've got a lot to talk about, and really appreciate you. I know you got back from a fishing trip, so you should be pretty energetic now for this academic nerd fest that we're going to try to have. So to start things out, to give the audience a little perspective on who you are and how you got to this place, why don't you tell us a little bit about your story? Because I think it's really fascinating.
Well, I'm a rural Midwest guy. I went to medical school in Baltimore and then proceeded to do surgical and orthopedic training at the University of Cincinnati, and was in practice for about 20 years in Sheridan, Wyoming. I had to retire after 20 years of practice because of diabetes that had shown up 8 or 10 years earlier. And then I began to have clumsiness of the hand, some pain in the feet, numbness and tingling, and that interfered with my capabilities. And I figured out how to retire from operation before I hurt somebody. So soon after that, probably 5 or 6 years, and now we're at about 2003, I saw in the Johns Hopkins Medical Alumni Magazine article about Professor Lee Dellon and his ideas about how surgery could be helpful in diabetic peripheral neuropathy. And I thought, well, surgery for neuropathy, that's the craziest idea I ever heard of. Everybody knows that this is a metabolic problem. But I read through the article and found that Dr. Dellon was saying one of the secondary effects of metabolic neuropathy and diabetes was that nerves became entrapped or pinched, and that relieving that compression on the nerves could resolve many of the symptoms of the neuropathy, including the pain, which was what he was primarily addressing. As I corresponded then with Dr. Dellon, he said, come on out here and we'll look at your feet that are giving you trouble, and I'll do nerve decompressions and we'll make things better, and then you can go back to work. But rather than go back to work after he had given me much improved sensation and relief of pain, I got really interested in expanding the ideas about what this nerve decompression could do, because there were murmurings among the people who were doing this surgery that the people didn't get the diabetic foot ulcers and infections and amputations that I had seen so much in my orthopedic practice. So at that point, I started getting involved in research with Dr. Dellon, and then independently and with other podiatrists and orthopedists. So that's how I got led into publishing and researching about these products, about the products of the peripheral neuropathy and its decompression. And that's consumed much of my last 20 years.
So it's kind of interesting. You were forced to retire, and then came across a little blip in one of the medical school alumni bulletins, and now we're here sitting talking about this. So that's kind of a interesting way these pathways are found in our lives.
You never know where things are going to lead. That's for sure.
Right. And I think you and I met, close to 20 years ago?
2004 at the first meeting of what became the Association of Extremity Nerve Surgeons.
Right. So I think one of the pushbacks that we've had over the last 20 years, and it's less now than it was certainly when I started doing these procedures in the early 2000s, is that people were going out saying that we're operating on diabetic peripheral neuropathy. And in fact, we're not. What we're doing is addressing superimposed nerve compressions that happen in patients with diabetic conditions, metabolic disease, because it sets up their nerves to become more swollen. And so I think the semantics messed things up a little bit as far as maybe some of the reluctance of acceptance of this surgery. And we'll get into the evidence-based medicine portion of this later. But would you agree that, maybe sometimes the way things are, termed or talked about can lead to some confusion?
Right. I think the people who don't see these nerves surgically, who never get a chance to see the fat, watery, edematous nerves, don't understand that it's that secondary change in size that is induced by the metabolic problem is what the difficulty is. Most neurologists don't ever get a chance to see this. However, there's at least a couple of neurologists in Italy, Rota and Morelli, who say this secondary enlargement of nerve and consequent entrapment is really the characteristic of diabetic peripheral neuropathy. So there are at least some of the neurologists who see these secondary compressions and entrapment neuropathy as being characteristic of the problem. So we're convincing some people with the evidence that we present.
Yeah, it's very interesting because you can literally read textbooks that are 5 inches thick about all of the different metabolic pathways of diabetes, diabetic peripheral neuropathy. Sometimes it boils down to, empirical things, like you have a swollen nerve in a tight tunnel. And in the upper extremity, neurologists have no problem whatsoever sending a patient with type 2 diabetes and diabetic peripheral neuropathy, whether it be in their legs or in their hands as well, over to the hand surgeon for a carpal tunnel decompression. And that's just standard. I mean, you ask almost any neurologist and they'll say, oh yeah, if they've got carpal tunnel, I'll send them on over. So conceptually, it's no different than the lower extremity. It's just a little bit of a paradigm shift. And when I've talked to neurologists, they'll say, yeah, that's interesting, but the lower extremity, sometimes it just doesn't get paid attention to. It's not on the radar as much as the upper extremity. And obviously that's where, Dr. Dellin made his first observations when these folks with carpal tunnel came back and said, you know what, I've got sensation in this finger and it's obviously less painful. And wait a second, we're not supposed to see that because we've been told and are still being told today that once you have this, it's irreversible and there's nothing that can be done. And we know that's not true. But I think sometimes it's kind of like Occam's razor, that we want to get down in the weeds so much, but we have to look at the simple thing. The nerve swells, it becomes edematous. Now, there are other things we know that can make nerves swell, but let's talk about some of the studies that are pretty objective are diagnostic ultrasound studies. Sonography has shown, and I think you pointed this out well, that in patients with diabetes, there's about a 25% increase in the cross-sectional area. And in patients with severe or painful diabetic peripheral neuropathy, it goes up to 50%.
And that is correct. And I think one of the problems with people being hesitant about nerve decompression for diabetic pain and complications in the foot is that hardly anybody understands that there are compression neuropathies, entrapment neuropathies in the lower extremity. The only one that a few people recognize and know about is the tarsal tunnel syndrome, which is quite similar to the carpal tunnel syndrome in the hand. But you talk to general practitioners, endocrinologists, and even neurologists, and they don't recognize that there are at least 4 or 5 places in the below the knee where you have potential for entrapment, where a fat nerve doesn't have enough room, and the consequent compressions occur and can be relieved by simple surgery.
It's very interesting, and we talk about the known sites of entrapment. It seems like every 3 or 4 years we get another known site of entrapment. I remember first learning, from Dr. Dellon that we had the common fibular nerve or common perineal nerve at the fibular neck, and then we had the tarsal tunnel components and the deep perineal nerve on the top of the foot, and that's pretty much what we addressed. And then we started seeing, well, wait a second, people that we decompressed, they would still have maybe some symptoms, burning or pain in the distribution of the superficial perineal nerve, where it comes from the lateral compartment into the subcutaneous space, and started decompressing that one. And now we've picked up a few more actually out in the foot, small ones, even like medial calcaneal nerves. So these nerves can be, I guess the point of all that is that there's a lot more sites of compression than what we really thought when we were first starting to get into this.
Absolutely.
So interestingly, I worked in a large internal medicine group when I was out in Phoenix, and I think they had 23 internal medicine specialists. And we would see patients, and their first presenting symptom was heel pain. And when we really looked at it, it was that they had medial calcaneal nerve entrapment. And then once we started really looking at them a little bit more and do 2-point, 1-point discrimination test these patients, we found that they had sensory deficits that they didn't even know because the onset was so insidious. But then all of a sudden, now I've got this map of both extremities, and they only presented with heel pain, and it wasn't even a plantar fasciopathy of the medial calcaneal nerve. And then by working them up, we'd send them back to the internal medicine specialist and say, hey, I think this guy is diabetic. It's like, well, how did you get that? And the answer is, well, here's how we got it. And that's the most likely thing. And then when they would do either an oral glucose tolerance test or they would do a serum fasting insulin, all of a sudden they was like, yeah, you're right, they are diabetic. And so a lot of times when I would ask those patients, well, when was it that you were diagnosed with type 2 diabetes? And they'll say, oh, a year or 2 after I started having numbness and tingling in my toes and feet. So it seemed like historically, at least in my clinical experience, many, I can't give you a percentage, many of these patients did, in fact, the first marker of their metabolic disease was the peripheral nerve entrapment.
That reproduces my experience as well. Often the neuropathy signs and symptoms were the presenting symptoms of diabetes. So anytime the heel pain or numbness or tingling would show up in the feet, you really ought to be checking for diabetes.
And then that brings me to the next topic, and that is the stocking and glove distribution, which I think it's mythical and dogma myself. And I know you're aware of what Dr. Andy Rader has done as far as sensory testing and all of the different components, but I don't know that he's published this just yet, but he has over 1,100 patients where they've done 1 and 2 point discrimination, and many, and I don't know the percentage, but it's very, very high, have normal sensation in the distribution of the sural nerve.
That's true, and it's also true that there can be early on an asymmetry between right and left legs, and also a difference in the nerve sensory areas between peroneal nerve and sural nerve and tibial nerve. So that has been published. It was Andy Rader, and Barry was his co-author. So That's certainly in the literature, and I think it attracted a little attention when it first came out, but it certainly hasn't been followed up by the endocrinologists and the neurologists. But it was one of my presenting symptoms. I had numbness, aching, and pain in the right foot. Nothing ever happened in the left foot. So I think that can be explained by a relative lesser or greater compression on these individual nerves that in combination produce something that does cover most of the foot and leg as a stocking would. But it's not predictable and it's incomplete. So a very interesting thing, but it was one of the things that convinced me that there is something to this individual nerve entrapment idea of Dellen's.
Yeah, and I think when you look at this type of a hypothesis, that lends a lot of credence to the edematous nature of the diabetic nerve being entrapped in a tight spot, because the sural nerve doesn't have a known anatomical tunnel. And so, and you make a great point too, is that why is it that one tunnel in one foot may be more affected if it is a systemic disease than the other foot? And the answer is, I think, that there are different vectors that are going on, particularly in the tarsal tunnel. If they have more of a pes planus deformity, that's going to cause a more of a pressure inside the tunnels. I mean, those studies have been done both intraoperatively and on cadaveric specimens. So when you look at some of the nerve entrapments in the lower extremity, there are explanations why some would be more early onset, maybe, or more severe than the other ones. So it's not like somebody's just lighting a candle or lighting a cigarette and everything's going up at one time. So I think that lends a lot of credence to the edematous hypothesis, the sorbitol. We'll talk about the biochemistry here in just a second. But the other thing that I thought was very compelling was from Dr. Dellen when he had a primate. And the primate was at Hopkins. I believe it was a type 1 diabetic primate, which is pretty rare, but it unfortunately died. The veterinarian knew Dr. Dellen, somehow called him down. They took some specimens from the ulnar nerve of the primate. They took a specimen like the mid arm and then one at the cubital tunnel. And now the histology was totally different. The nerve in the mid-arm, where there is no site of entrapment, it had swelling, just like what Jacobson showed back in 1978. But the myelin was still relatively in good shape, and the contiguity of the nerve was still relatively normal. But when you got 2 inches south down to where the cubital tunnel was, it was like a bomb had gone off in this nerve. So there was no way for me to believe that this was solely a metabolic process, because if it was solely a metabolic process, then why does that nerve look so different 2 inches, point A to point B?
And that kind of change at the sites of compression has been demonstrated again in rats, and also been shown to resolve to a significant degree if decompression is accomplished at the compression sites in these rats that have had diabetes induced. And it happens quickly. It happens within a matter of weeks. I believe 8 to 12 weeks, you can see the changes happening. And then within 6 to 12 weeks after decompression, you see much improvement. So I think there's pretty darn good animal laboratory evidence of resolution and improvement in the ultrastructural histology of nerve in both animals and clinically in humans.
Yeah. So now we do have objective sonographic evidence of nerve swelling in patients with diabetes. We have demonstrative changes in animal specimens with models of compression. And then you also have significant intraoperative electrical findings as well. I want to talk to you about that because I think you were in the OR when we did that small study with the independent neurologist with the nerve monitoring. But before I touch on that, and I'll put this in the show notes so people can look at it. But do you want to explain the process of sorbitol and what's going on with the hexokinase pathway just briefly?
Well, you put the carpenter in the biochemical laboratory, but really what is going on is that there's a normal pathway in which glucose gets turned into energy. But when you have continuing high glucose levels, that hexokinase pathway for providing energy is overwhelmed, and the excess glucose is metabolized in an aldose reductase pathway, which leads to an accumulation intraneurally of a sugar alcohol named sorbitol. And that sorbitol within the nerve yields a hyperosmolar situation, and you have fluid migrating within the nerve across the epineurium so that the size of the nerve increases, and you get a fat nerve merely on the basis of fluid migration. And that's what makes the fat nerve, and that's what yields the compression and entrapments, and relieving the entrapment by opening the tissues around the nerve is what gives you the relief. And that's what the nerve decompression is.
Yeah, and I think that was established in I think it was about 1985 muscle and nerve study with Dellon and McKinnon, where they took models of, I don't know if it was primate nerves or I think it was, but they would take a nerve, they would put a silicone tube around the nerve where the inner diameter was a little bit bigger actually than the external diameter. Then they would make these animals diabetic by giving them streptozotocin and knocking out their pancreas. They became pretty sick, 400 blood sugars, cataracts, a lot of stuff went on. And then they developed a model of compression. They showed these histological findings that we've discussed, like in the forearm and then the cubital tunnel. And then they would decompress, take the silicone off, and this nerve would regenerate. And that was a shocking thing for me when I first learned about it, because again, we were taught, it's irreversible. And especially with the diabetic, they don't have any reparative mechanisms for nerve regeneration peripherally, but the answer is they do, in fact. And so that was another side, a very compelling study. But the point is that we're getting into some very objective things. These are not subjective, right? And so when we get into the discussion of evidence-based medicine, you start stacking all of these things together. It's pretty hard to overcome the hypothesis, not only because of the bench work, the laboratory work, but also because of the outcomes from peripheral nerve surgical decompression. I think one of the things, when we worked on that study, I think it was about 11 patients, and sadly, for reasons that were out of our control, it never got published. However, it did get presented in an abstract form at one of the American Academy of Neurology meetings, was the incredible changes in amplitude of the EMG intraoperatively.
Right. And just to expand there on your discussion, the much of this work was done in both mice and rats. And if you want to look at these histology things and search authors such as HU, TU, and Dellon, you'll come up with 2 or 3 papers that have excellent results reported that shows the disease and the complications develop and then being reversed by removal of the compression. So that's very good way for folks who want to look at the original research.
So let's go back to those days we spent in the operating room. I think the neurologist was shocked because, here he is getting a baseline reading, and then 2 minutes later, after we take the first site of entrapment off that nerve, all of a sudden it's going from, 200 to 1200. And there's no placebo there. I mean, the patient's asleep. That's pretty compelling evidence.
Absolutely. Very, very convincing in my mind.
I remember Sonny Yamasaki telling me that he didn't believe it. Even when he saw it, he was like, I can't believe this, And Sonny is one of the, smartest guys I know when it comes to peripheral nerve.
Yes, and he and I were just discussing this in the last day or two, and he at that time was the director of new therapies for the Medtronic company, which manufactures a lot of medical devices. So he's a well-educated, very experienced fellow, and like you, any room he walks into, I always think he's the smartest guy there.
Well, you're right on 50% of that, but anyhow, so let's talk about the increase we saw in blood flow too, because this is one thing that's really counterintuitive.
One of the studies used people who had kind of early atherosclerotic cardiovascular disease to the point of having potential loss of skin tissue. And this was measured on the top of the foot by transcutaneous partial pressure of oxygen measurements. And it was an Italian group, the lead author being Trignano, Trignano. And they had 20 people, and they had bilateral loss of transcutaneous PO2s to the point of being ischemic and at risk of skin loss. They did nerve decompression on all of these people, and 39 out of the 40 feet recovered their TCPO2 out of ischemic levels and into more normal levels. In addition, 6 of those people had a foot ulcer at the time of those surgeries, and all of those ulcers healed. None of them recurred in the following year and a half, whereas you would have expected somewhere between 35 and 50% of those ulcers to recur just in that year and a half. A very powerful paper.
We did another study, again, just a handful of patients, but when I was in practice down in the Woodlands, Texas, we had a very good wound care center that had hyperbaric, and the director up there was a really wonderful guy. And I sent him up about 6 patients where he did laser flow Doppler on these people, flowmetry. And then I would send him up at about, I think, 6 weeks post-op. And he called me up after about the 3rd or 4th patient, and he said, I don't understand what's going on here. He goes, their blood flow is like dramatically, 1,000% improved. Their response to thermal stimulus, 3,000% improved. He was just blown away by it. And so I think there are some applications for this surgery that, not only restoring sensation, but one of the things that we've been doing over the last several years that seems to be good is that if these patients, if they have really poor, xerotic skin, their autonomic function's bad, and you just don't want to touch them below the ankle. You just can't, because they're not going to heal very well. But if we do a more superior decompression, like common perineal, maybe sometimes superficial perineal, it's really incredible to see how the vascularity of that foot changes to the point where we can then go on subsequently down the line and actually do the tarsal tunnel decompression or any other decompressions needed in the foot. And I think that provides some tremendous value for us to be able to get the foot somewhat vascularly reestablished, and then, it's safe to go on and do something. But that's just one observation that we've seen that's been pretty incredible.
Let me add one other. You and I may have not discussed this because I only discovered it a couple of months ago, but it's a paper from Japan. The lead author is Uemura, and they were using a technology called SPY, and that is a vascular injection of indocyanin green dye. And they found that in the first minutes after nerve decompression, that the vascular flow at the tarsal tunnel where the decompression was done increased by 30%. It was a small number of patients, but it was another demonstration that you're really doing something for the neural control of circulation distally to those sites of decompression.
Yeah, you'll need to send me that. I'd love to see that. I'm sure there's probably some great color illustrations showing the SPY before and after. So we've got improvement in EMG intraoperative findings. Jim Anderson published some nice stuff on that. And I think you were actually co-author and helped steer that research quite a bit.
Right.
Tell me what you can recall from that. Because I thought that, first of all, I thought it was a great study, and it got published in a really respected journal.
Well, Jim was real interested in what happened when you did these nerve decompressions in terms of the neurophysiology, the electrical activity of the nerves and the muscles. So we got talking about how you measured that, and the way that they measured it was with the nerve integrity monitoring machine, an NIM. And that machine could measure the motor evoked potential of a muscle that was being stimulated after decompression. In this case, they were measuring the motor evoked potential in the tibialis anterior and peroneal muscles of the lower leg after the nerve decompression was done on the common peroneal or common fibular nerve just below the knee. And in those cases, about 75% of people had a really significant increase in the motor evoked potential. And this could be demonstrated intraoperatively in the period between 60 and 100 seconds after you do the nerve decompression. So it was an immediate intraoperative improvement in the neurophysiological functioning of the muscle and the nerve neuromuscular junctions. So that was very, very impressive. There were also some demonstrations when you did the tarsal tunnel releases and measured the abductor hallucis motor evoked potential and the abductor digiti minimi motor evoked potentials, reflecting the functioning of the medial and lateral plantar nerves. And some of these were 400 or 500% increases in just 60 or 90 per seconds. Just stupendous, immediate improvements intraoperatively that could be recorded.
So one observation that I've made over the last 20 plus years doing this is that when we decompress a nerve, the motor function is absolutely the first thing to return for a patient. And you would think that, well, there's a high correlation. If I see a patient immediately post-operatively or 1 week post-op, and they now have complete tibialis anterior function or extensor lucis longus function, generally speaking, their sensation is going to improve and there's going to be a significant restoration. We do much better with pain than we do with restoration of sensation. I think that comes down to the robustness of the A fiber, the motor fiber versus the A beta fiber. I think the A beta fiber might be a little bit more frail or have some more fragility to it, but there is not a one-to-one correlation. I have a fair amount of patients who I've restored their motor function and their balance is better because they now can, dorsiflex their foot, but they've not had significant restoration of sensation.
Yeah, I think there's probably also some effect on the proprioception that is going on in the muscles and tendons too, that is responsible for some of that recovery of balance and strength as well. Interestingly, it's now 20 years since I had decompressions, and I find that I have had over the last 4 or 5 years probably noticeable weakness, both of ankle control, of tibialis anterior, such that deceleration and control of going downhill is a problem. And then also just quad weakness and hip weakness too. And I think what's going on is that's a reflection of the continued metabolic neuronal damage, and not due to the entrapment of axons that is happening distally at those sites of fibrosis tunnel entrapment. So that's been kind of an interesting observation that in my own situation as it's gone on for 25 or 30 years.
Well, there's been, some things published about improvement in balance, and we know that if you don't get killed by a car accident and you're over 65, your chances of dying are very high from a fall. I think it's the leading killer. And I'll try to find a stat and correct that if it's wrong in the show notes. But there was one study that said there was no improvement in balance. I think that was Mark out of Denmark or Holland. And
those people were doing unilateral decompression, and the original papers about improved balance noted that unilateral decompression does not give you an improvement in balance, and it requires bilateral nerve decompression to get an improvement. And Van Marek missed that.
Yeah,
she did only unilateral decompressions and measured.
Well, certainly in my clinical experience, I've had a very good amount of patients that have had improvement in balance, and sometimes, believe it or not, they were only unilateral, but again, they were just greatly affected in that one extremity and not as much in the other. But yeah, I agree. It needs to be a bilateral decompression. So we've got improvements in balance. We've got electrophysiological changes. We have ultrasonography. I mean, we're stacking up some pretty serious evidence here. But I think maybe if we want to talk about the most serious thing is, let's talk about ulceration and amputation, because there is no placebo effect if you lose a toe or you develop an ulcer. And so share some of your stuff with that. And then after that, let's talk about cost and how much this procedure could actually save our global healthcare system.
The objective findings are quite impressive. And all of this pain relief and sensory change, those are subjective things, or at least semi-subjective, because all of the ways we measure those things depend on patient reporting. But if you're talking about objective outcomes, you're talking about things like, do you have an ulcer or do you not? Do you develop an ulcer after having healed one previous ulcer, or do you not develop another ulcer? And the risk of having another ulcer is about 40% per year, according to a New England Journal of Medicine article in 2017. David Armstrong was one of the authors there. That, however, does include both neuropathic diabetic foot ulcers and the double whammy of neuroischemic diabetic foot ulcers. So we don't quite know what the neuropathic only ulcers do. And Dellen's operation so far has been directed only at the neuropathic problem. Now, that Trignano paper that we talked about says that even in a neuroischemic even in a neuroischemic situation, there, even though it might be milder than the serious limb-threatening ischemia, there is some benefit in at least those mild cases. And I'm very anxious to get people researching about doing a combination of reestablishment of circulation, and decompression of nerves as a combination for a research study, so that we can see this benefit extended to a much larger group of people with the cascade of diabetic neuropathy complications.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15. So you shared an article with me, I believe it was June or May, might have been I lose track of time, might have been a few months before that, where they had shown these changes in the pressure receptors in the sole of the foot. And do you recall that?
That would be pressure-induced vasodilatation,
right.
A phenomenon that is present normally, but it's absent in diabetes and worse in diabetic neuropathy. And we don't have any information on whether that can be reversed with nerve decompression in diabetes. We do know that in a similar situation that transferred flaps, which have nerve supply in addition to better circulation, survive much better than non-innervated flaps. So that suggests that that better innervation is an important part of restoring that pressure-induced vasodilatation. Now, that phenomenon is something that increases the blood flow to the skin with gradual increasing pressure, such that if you were standing on your feet in comparison to lying or sitting with insignificant pressure on your feet, the blood supply can be increased by approximately 45%. That may be the whole explanation of why nerve decompression is so effective in healing the initial diabetic foot ulcers and in preventing a recurrence of the foot ulcer.
Yeah, and I'm just going to try to hypothesize here, but there's always been this debate about what's happening with the small fiber. And when we first started doing epidermal nerve fiber density biopsies, we didn't really see any changes post decompression, but we were only looking at them 3 months, 6 months down the line. And then I started seeing a few patients that actually were like a year post-op, and they wanted another epidural nerve fiber density biopsy. We did, and they had it reestablished completely normal ENFD counts, which was really astounding from the standpoint. So how much of the continued burning in some of the folks that we decompress is there because they don't get a reestablishment of these small fibers, or the people that all their burning goes away have a good reestablishment. I mean, that's something that I don't think anybody's really published anything on that, but it's certainly an interesting thing to look down into.
I agree, and one of the things that you should that we should all keep in mind is that if you repair a nerve, the regrowth of innervation past that repair site, which is what a nerve decompression would be,
right?
It would be equivalent to a repair site, and that only occurs at about a rate of 1 inch per month, and probably slower than that in the adults that we're operating on with diabetes. So if you're talking about relief of burning at the toes, you would expect it to take at least 4 to 6 months before you'd start to see that regeneration of the small fibers getting out there to the toes.
Right. Yeah, it's very interesting. So we can do a lot. Some of these people are hopeless. Actually, they've had so much pain for such a long period of time, or they've had so much pain and ulceration that they've been in, the wound care clinics way too much time. And, that's something that I think is interesting about this subject, is because there's many facets that we can, discuss. Ulcer prevention of recurrence after they've had an ulcer, the pain aspect. I mean, we do all types of nerve, but probably if I had to give an estimate, about 10% of our nerve patients are suicidal, and they'll admit to that because it's just such a horrible thing to have chronic nerve pain. So I think there's a tremendous amount of utility for this technology. I'm frustrated that, Lee introduced this in the early 1980s. We've been talking about it, educating people, training surgeons. What's it going to take for us to get to the next level and get this, integrated into what some people would call mainstream medicine?
I know that you've seen this time after time, but people will come to you after surgery and tell you that you saved their lives because they were suicidal from the degree of pain. And what a wonderful thing to be able to anticipate, at least on some significant number of occasions.
So, is there anything we have not talked about that you want to chat about? Because I think it's, we could go on for days with this, but I think we've covered a lot. But you've been really embedded in a lot of research over the last 6 months. So is there anything that you want to share with us?
I think we've mentioned the things that have been new to me, as Dr. Yamasaki and I have been working on a comparison of the benefits of nerve decompression in preventing initial ulceration and recurrent ulcerations in the diabetic with peripheral neuropathy in comparison to standard of care. So I've had an opportunity to refresh my memory on that whole panoply of information. I think we've hit all the high spots here. So I think we could let it go at that. And it's probably much more than most of our audience will have been aware of. And that's a good place to start.
No, I think it's been great. I think it's been a great discussion. I want to thank you for taking the time to do this. And I know we're going to come back and circle in on maybe some of the more esoteric stuff as we get going down the road with this podcast. But Scott, thanks so much for all you do. I would like to encourage any of the listeners, if they want to find out more about this information, that the Association of Extremity Nerve Surgeons, the website is aens.us. Would highly encourage them to come to our annual meeting. I think that from a podiatric standpoint, it'll be a meeting unlike anything you've ever seen. You probably won't even hear a term like osteotomy the whole weekend, but it's a fascinating topic. And I know, a lot of people that I have introduced into the nerve world, they just gradually have migrated more and more into it and out of what you would call regular podiatric medicine and surgery. So if you do have interest, there are a lot of resources out there. And Scott, I look forward to seeing you in a couple of months out at that meeting.
I'm planning to be there. And I would also just encourage, if any of the foot and ankle orthopedic group come across this information, I've had difficulty getting them interested in this topic. And I know that the foot and ankle orthopedic people see a lot of these problems as well. And the appreciation of what nerve decompression can do for the folks suffering from either pain or other physical complications. Some of the people go through the orthopedic entry to this, and I hope that we'll get much more appreciation in the orthopedic group of what can be offered and the benefits that can accrue using nerve decompression. And if folks would like to correspond with me, I don't mind having my email out there, which is THENIX at fiberpipe, FIBERPIPE.net.
And Scott, I'll put that on the show notes as well. So they'll have a hyperlink that they can connect right to that and get in touch with you. Well, thanks so much. I want to let you go. I know you got some other meetings and whatnot, and look forward to seeing you soon.
I really appreciate the opportunity to talk about this. It's been an exciting topic for me for the 20 years I've been involved.
There's been nothing like it for me. I mean, nerve was the ultimate seductress, and it took me down the hole so quick. I'll never get out of it. And, I've been fortunate enough now. I've had 5 nerve fellows. My 5th fellow just started about a week and a half ago. And I think I already have her totally hooked, so it didn't take long. And so that's what we want to do is,
Indeed.
We got to get more people trained. That's really what it amounts to. And there is no shortage, sadly, there's no shortage of patients out there who need this work. And it's life-changing stuff. It's really, really important. So thank you. I can't tell you how much I value your collegiality, but more so your friendship. And the next time we talk, we have to have it Cabernet assisted.
I'll look forward to that.
All right. Be well, my friend.
Thank you.
All right, Scott. Bye-bye.
Bye-bye.
I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.